Hello, this is Dr. Andrei Javier
and Khaled Abdel-Kader from Vanderbilt University Medical Center, here to discuss our recently published article, Nephrology Provider Prognostic Perceptions in Care Delivered to Older Adults with Advanced Kidney Disease. Most older adults with chronic kidney disease die before reaching end-stage renal disease, and many of these patients have multiple chronic illnesses. Yet, as nephrologists, we often focus on slowing kidney disease progression and preparing for dialysis, spending relatively little time discussing goals of care or advanced care planning with these patients. Several recent studies show that patients with advanced kidney disease who eventually die are more likely to receive aggressive care and less likely to use hospice services near the end of life.
We wondered whether more aggressive end-of-life care could be driven by the challenges of estimating prognosis in advanced kidney disease. After all, patients with kidney disease often experience sudden death. In addition, unlike other chronic diseases, we can replace kidney function, and that may alter prognosis. We hypothesized that patients assessed to have a poorer prognosis would be more likely to receive conservative management, to have an advance directive or medical order about end-of-life care, and to die at home and with hospice services.
To test our hypotheses, we identified patients over 60 years of age with advanced chronic kidney disease and who were following up with a nephrologist at our local university-based outpatient clinic. Immediately after the nephrologist saw the patient, we asked the nephrology provider the surprise question: would you be surprised if this patient died in the next 12 months, and recorded these responses.
The 488 patients included in the study had a median age of 71 years. On the whole, patients had numerous coexisting illnesses. The median estimated glomerular filtration rate was 22, and we followed patients for nearly 2 years. Providers responded, "No, I would not be surprised if this patient died in the next 12 months," for 35% of patients. During follow-up, 33% of patients where a nephrologist answered no to the surprise question died, compared to only 10% of surprise question yes patients.
We found that it was uncommon for patients to have a documented preference for conservative management, regardless of how the nephrologist answered the surprise question. However, it was higher among the surprise question no patients at 13%, compared to their surprise question yes counterparts at 2%. Similarly, we found that only 13% of surprise question no patients had a medical order, though this was higher than the 5% we noted in the surprise question yes patients. Almost 90 patients died. The location of death did not differ by how nephrologists answered the surprise question, with about 40% of patients dying at home or hospice in either group. Hospice services were used for only 38% of the surprise question no patients, and 26% of surprise question yes patients, a difference that was not significant. In addition, a majority of the patients who died were hospitalized in their last month of life, including 54% of the patients in the surprise question no group and 67% in the surprise question yes group.
Our findings highlight that there is only a modest difference in advanced care planning and end-of-life care between chronic kidney disease patients with clinically recognizable high-risk or low-risk features. We think our findings highlight several important issues. First, for older patients with advanced chronic kidney disease, improved prognostic accuracy alone is unlikely to increase the use of advance directives and hospice services in the last years of life. Second, the surprise question may be a simple, pragmatic tool to assess mortality risk in the hands of nephrologists caring for older patients with advanced chronic kidney disease. And finally, there is a need to understand informed patient preferences. For example, when patients with advanced chronic kidney disease are reasonably informed of their anticipated quality of life and prognosis, what are their health priorities and care preferences? And are we honoring them? Thank you for listening.
This podcast is copyrighted by the American Society of Nephrology, all rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare provider if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast of the American Society of Nephrology.